Us by our respectable speaker, Dr. Sidrah Andaleeb. I would like to give a brief introduction about our respectable speaker. She is PharmD from Lahore College for Women University. She has done her MPhil in pharmacology from Punjab University. She is also a US board certified pharmacotherapy specialist with added qualification in infectious diseases. She was second BCPS from Pakistan and first BCPS certified female in the subcontinent. She has worked as a head of clinical department and subsequently deputy manager pharmacy in Shaukat Khana Memorial Cancer Hospital, Lahore. She was the residency program director of residency at Shaukat Khana Memorial Cancer Hospital and led the program to successful accreditation as the second ASHP program across the globe. She has been officially involved in a hospital pharmacist training programs, including training program by Pakistan Pharmacy Council and primary and secondary health department. Also the member of Medical Microbiology and Infectious Diseases Society of Pakistan. She has been member of ADR Scrutiny Committee of Primary and Secondary Health Department, Punjab. She is currently in Ontario, Canada. I would like to give a very warm welcome to our today's speaker. Assalamu alaikum, ma'am. How are you?
Walaikum assalam, Dr. Rida. Thank you so much for having me.
Thank you so much, ma'am, for giving us time and preparing that much informative presentation for our participants. Now, without further delaying, I would like to hand over our session to you to begin your lecture. Over to you, ma'am.
Thank you very much, Dr. Rida. Assalamu alaikum, everyone. Thank you, Dr. Rida, for the introduction. And this actually is an honor for me to be part of this good venture. Obviously, you guys are all in the process of learning. Anything that involves learning is ibadat. So we all should take it like that. And it's going to be, I hope that all of us are going to learn in this process today. So gastrointestinal disorders actually is a very important and a big chapter in the BCPS preparatory course. And all of you guys who are going through that, there are few chapters which are very big, like men and women health, specifically in gastrointestinal disorders, and also very important whenever you talk about it. So without further ado, we're going to start with the lecture. I have no conflicts to disclose. Our learning objectives today are going to be talking about the basically pharmacotherapy, the education, and the pharmacologic and non-pharmacologic treatment modalities that can be there for management of gastrointestinal disorders. Now, in these disorders, what we're going to talk about section by section is the gastroesophageal reflux disease. We're going to talk about peptic ulcer disease, ulcerative colitis, Crohn's disease. We're going to talk about chronic liver diseases. We will touch specifically on hepatitis C. And if we have time, we'll also talk about hepatitis A and B. Then we're going to talk about constipation and diarrhea, irritable bowel syndrome. We'll touch pancreatitis and upper GI bleeding also. So it's a huge lineup, and let's get started with that. So what we're going to do in the format that I've thought out, what we'll be following in this talk today is that we'll have case-by-case analysis of the pharmacotherapy of disorders that we're going to discuss. For instance, let's get started with our first section, which is gastroesophageal reflux disease. So I want all of you to learn this or go through this case with me, and let's see what we can do in this particular case. So this presenting case in front of us is a 55 years old male. It has 8 months history of, sorry, I can't say 8 months history of GERD. Can you guys hold on a second, Dr. Rida? Can you please help me to minimize this? I can't minimize this. and just to be able to see, probably.
Sorry, ma'am.
I'm unable to minimize.
No
So
problem. You may have your time.
yeah, just a second. So this Pepsia symptoms, because the screen is actually obscuring me. Yeah, no. So with my out of the box IT skills, I've just moved it apart. So it's a 55 years old male with 8 months history of GERD symptoms, which are 4 to 5 days a week. He's currently on lansoprazole, a proton pump inhibitor, 15 milligrams per day. He has no ulcers or erosions via endoscopy. His past medical history is he's hypothyroid and he has had diagnosed GERD. So his medications currently are lansoprazole 15 milligrams once daily and levothyroxine 100 micrograms daily, right? So which treatment approach is best for this patient according to your assessment? Should we add metoclopramide 10 mg 4 times per day? Should we increase lansoprazole to 15 mg twice daily? Should we switch to omeprazole 20 milligrams daily? Or should we add sucralfate 1 gram 4 times per day? So as we talk about GERD, let's do the thought process in this case. So GERD, we all know this is a coercion of the symptoms which involve dyspepsia, dysphagia, and persistent symptoms. So we start with non-pharmacologic treatment by eliminating the factors, the risk factors, and we do the lifestyle modification. The next step is you try to do over-the-counter treatment like some antacids probably, which include the aluminum-based and magnesium-based antacids specifically. Then we move to acid suppressants, which we call as the anti-secretory therapy, which include the proton pump inhibitors and the H2 receptor antagonists. To be specific, if the patient is not responding on these, we do the further endoscopic evaluation, and if a diagnosed motility disorder is there, we add a pro-motility agent. So the pro-motility agents actually do not come before further diagnostics have been done on a previously identified GERD, right? And lastly, there is surgical intervention. So that's how we go about in this. So my apologies for can't really. My apologies, just a second.
No problem, ma'am. You may have your time.
So, oh, sorry, thank you. So we go from non-pharmacologic treatment initially. If that doesn't work, we add antacids. If that doesn't work, we add acid suppressants, which we call as anti-secretory therapy. If this is not working, then we do the invasive or the non-invasive diagnostic tests to identify the motility problems or another pathophysiology that may be there in the patient. So if you find out motility disorders, then you add a pro-motility agent like a D2 antagonist, like metoclopramide or domperidone and drugs like that. And if required, you may go for a surgical therapy also. So that's our way to go about it. So our diagnosis as of the GERD guidelines, and 2013 में आई उसके बाद दोबारा नहीं आई, यही चल रही हैं. So diagnosis is basically empiric proton pump inhibitors with typical symptoms. So all the typical symptoms of GERD, if they're there, you don't need to go for specific endoscopy or try to do an invasive or blood sample or anything. You just start with proton pump inhibitors empirically with the typical symptoms. H. pylori screening technically is not required, right? It's not required in a general population. It may be required in cases where there are specific symptoms of the patients who are susceptible. So we do the non-pharmacologic management of GERD, which is like patients who are on the higher side of the weight, they have more pressure towards the diaphragm, more pressure on the pyloric sphincter. So increased chances of acidity and reflux and cough and everything, right? And you also elevate the bed to 45 degrees. So ask the patients not to lie straight. As we all know, they should have a higher bed. No smoking, no caffeine, no nicotine, no spice. So we do not ask for global elimination of all foods, because that doesn't make sense, since it's a long-term problem and it's not practical to ask the patients to leave everything. But you ask them to remove the triggers. So the triggers could be remove smoking, remove caffeine, and remove spice from their foods, right? And lie with the heads high, and also weight loss. So these are the kind of non-pharmacological education points that you suggest and counsel to the patients. For the treatment, if it's a non-erosive esophagitis, non-erosive means that patient may have, it's a lower risk case, right? So non-erosive, that a continuous regurgitation of the acid may cause the damage to the esophagus, and as a result of that, there may be erosion. And in the worst case scenarios, you may have a Barrett esophagus. Barrett esophagus kya hai ki, your usual esophagus is squamous epithelial cells, which are not apt at dealing with the acid as much as the intestinal organs. So if there is continuous reflux, the body adapts and changes the squamous epithelial cells to the columnar epithelial cells. And there are higher chances of, so because of this specific change in the configuration of the cells, there are higher chances of carcinogenesis also, right? So that's the worst kind of erosive esophagitis. You call it a Barrett esophagus. So if there is non-erosive, it's proton pump inhibitors for 4 weeks and reevaluation. If it's erosive esophagitis, it's proton pump inhibitors for 8 weeks and reevaluation. In a lot of cases, like in 50 to 60% of the cases, you may need to continue proton pump inhibitors even beyond 8 weeks. So as for the mnemonic, Islamabad के घरों के number नहीं है, but it's just like a mnemonic. N4, F6 तो सबको पता है. Just remember N4, non-erosive is 4 weeks, E8, erosive is 8 weeks, right? N4, non-erosive 4 weeks, erosive 8 weeks. So maintenance therapy is there with the proton pump inhibitors. If the patient has specific nighttime symptoms, so the patient is taking proton pump inhibitor in the morning. If the symptoms do not resolve, you can split the dosing, like give morning and evening PPI, or you can add an H2 receptor antagonist also. So there is evidence for that also. And the dosing is obviously you give 30 to 60 minutes before the meals. You start with once daily dosing, and AM and PM can be done. So H. pylori specifically, importantly, is a carcinogen. If it's diagnosed, you should always treat that. So with the proton pump inhibitors, you have esomeprazole and the dosing, you can see 20 milligrams, maximum 40. So they usually revolve around 20s and 40s, 30s and 60s, not more than that. So if you get a question, for instance, in the exam mentioning any dose, say 80 milligrams or 100 milligrams, that's not a usual dose for GERD or for peptic ulcer. So it's just to give you an idea of what is a usual dose. You all know 20, 40, 20, 40, so they revolve around that. The newer agents like dexlansoprazole is 30 milligrams once daily, and 60, it's a longer acting agent. To be very specific, with proton pump inhibitors, half-life is a misnomer, since they completely destruct the pump. And a new pump is to be formulated, which does not form at least 24 hours till the action of omeprazole. So the half-life is no predictor of the action. It actually works for 24 hours. So it should be good for 12 to 24 hours, provided the dose is there, right? So esomeprazole, strontium, and dexlansoprazole, these are the newer agents. It can also be given once daily and have as much efficacy as a Q12 hourly dosing of the proton pump inhibitors, right? And I'm sorry to cut you off, Dr. Rita, can you please guide if somebody has any question, how during my talk, they can obviously.
Not right now, ma'am.
Because there's somebody who said, please use presentation mode. I don't know. What does that mean? Can you see the slides clearly?
Yes, the slides are already in the presentation mode.
Okay, so with the proton pump inhibitors, there are safety concerns. So we have no issue with the PPIs. You see, P is for PPIPs, but proton pump inhibitors are actually, I would call them the puppy of GERD and the puppy of peptic ulcer, since they're going to be everywhere. Whenever you come across a patient with GERD, or come across a patient with stress ulcer, or you come across a patient with peptic ulcer, proton pump inhibitors are going to be there. So they do not go off, right? But there's safety concerns with these drugs, and we all need to be very clear about them, and we need to monitor the patient and guide the patient accordingly. The most important is the fracture risk. So you see, these kind of issues like GERD specifically are cases of age more than 40 years, 50 years, 60 years. And the fractures, decreased bone mineral density is also a case of later parts of the life. So they enhance the risk. They have been associated with enhanced risk of hip, wrist, and spine fractures. But the guidelines say that this increased risk should not dictate the reason for using the decision to use a PPI. So even if the risk is there, you just continue with it. So it's just something you can live with, right? So risk should not affect the decision to use. They can be used in osteoporosis, but you limit the dose. You don't try to go with the dose related as well as duration related. So you don't want to dose them very high, and you try to limit the duration as much as possible. And you also recommend calcium and vitamin D, supplementation in susceptible cases. If the patients are at low bone mass density, like patients with osteoporosis, you calculate the see the T-score on the bone mineral density. So bone mineral density may be, BMD may be ordered for such patients. And weight-bearing exercises as a lifestyle modification to the patients should be suggested. So yes, fracture risk is a big risk. Then they cause hypomagnesemia, right? Now this is something, if the patient suffers hypomagnesemia with a proton pump inhibitor, you reevaluate the need for continuing the use of a PPI. तो अगर वो जिस तरह अस्पताल से या क्लिनिक में आया और वो उसके हाथ में पकड़ाया और वो फिर खाता ही चला गया, like something you have to continue for a long period of time. This usually happens with PPIs, right? So you need to reevaluate. Is there a need to continue specifically? You also, and in this case also, you limit the dose and you limit the duration of use of proton pump inhibitors. So you do the baseline testing for magnesium if the patient is on a proton pump inhibitor, and along with that PPI, the patient is also on another drug which reduces magnesium levels. For instance, like diuretics or a drug like digoxin, which has a documented hypomagnesemia effect. So in such patients, you need to do baseline magnesium levels, and then you provide supplementation accordingly, right? C. diff diarrhea. So now this is interesting. So you see, when you disrupt the acidic environment in the body, it actually disrupts the bacteria also, the good bacteria also. So that you are increasing the pH, making it less favorable for the acidic bacteria, right? So this natural selection, this process may naturally select Clostridium difficile in the body, and the risk of C. diff is there. So in that case also, you need to reevaluate the need. You ask the patients to report diarrhea. So if the patient has been prescribed long-term PPI, which usually is long-term, they usually go for a minimum of 4 weeks, even if it's a non-erosive one, it's a minimum of 4 weeks. So you ask the patient to report any diarrhea, right? And C. diff is a risk, yes. And something which is very new and recent and is getting a lot of attention is community CAP. This is community acquired pneumonia. So the risk of infections with PPI is a concern also. The reason I spent too much time here is because I got to one question in my exam from this. There's one question regarding hypomagnesemia. And I think that this is an important thing that you guys could have. And also from the practice point of view, almost every other patient is on PPI. Like I said, PPIs are the puppy of GERD and peptic ulcer. So you need to be very clear about what are the risks. And this community acquired pneumonia has been shown with even a short-term period of use of PPIs. So the long-term risk needs to be still evaluated. It's not yet identified. Important interactions are obviously, there are a lot of interactions. Omeprazole and clopidogrel. And now studies have time and again refuted that, but this still keeps on coming. The patients who are on clopidogrel, should they continue with omeprazole or not? The significance level keeps on switching between B and see, but just be on the safe side. If your patient is on clopidogrel, you don't want the patient to have a thrombotic event, so you just switch omeprazole to pantoprazole, right? Similarly, the patient is on methotrexate, on a chemotherapy, omeprazole, you switch to ranitidine, right? So the levels of methotrexate may be higher, and the toxicity of methotrexate may be higher also. So it's an efflux inhibitor, omeprazole. It's going to increase MTX levels, methotrexate levels. Similarly, with protease inhibitors, reverse transcriptase inhibitors like raltegravir, and also with velpatasvir, that's an hepatitis C medication we're going to discuss in the chapter. So omeprazole plus raltegravir, there are increased raltegravir levels. The levels of raltegravir may also increase, right? Now, coming back to the case that we started off with, this was a 55 years old male with 8 months history of GERD, but his symptoms are persisting 4 to 5 days a week. This is like most of the days of the week. So currently he's on lansoprazole. There are no ulcers or erosions. He is hypothyroid also. He has GERD. He is on lansoprazole 15 milligrams once daily. What do you suggest? Can we have any comments in the chat box? So there's one question. Ranitidine is a very good question, Hamza. Very good question. So ranitidine is out of the market. Famotidine is the alternative. Famotidine is there. You can use famotidine like we have been using in practice. Any other question, ma'am? GERD management, just let me split it sometimes on one night. So the usual duration of action of omeprazole is around 12 to 14 hours, like for one dose, it's 12 to 14 hours. And the pump usually takes around 16 hours. So in the later period of the day, the patient may have symptoms, right? So the usual time for the pump to regenerate is around 15 to 16 hours. So you can call it a day, but it's not a complete day. So in the late night, the patient may complain of dyspepsia, of cough, right? So to manage those, you give a drug which has the peak during that time. You can add an H2 receptor antagonist or just split the dose of PBI, to be honest. So discussing the case, you guys are saying right, Sarvat B and Naila B, this is all very good. So add metoclopramide 10 milligrams 4 times a day. We all discussed that you don't add a pro-motility agent unless you have further diagnostics available that there still is an underlying motility disorder. In this patient, we have no information of that. So that's out of question. We don't add. Option C, switch to omeprazole 20 milligrams daily. So proton pump inhibitors have no preference of one PPI over the other. Lansoprazole, pantoprazole, rabiprazole, omeprazole, they're all equivalent in their response. So there's no point of switching from lansoprazole to omeprazole just because the patient is not responding. You don't expect a change in the pharmacotherapeutic effect, right? Sucralfate is not the drug for GERD. And anyways, it's just a symptomatic treatment. So there's no point of adding sucralfate. But lansoprazole therapeutic dose is 30 mgs. So he was taking 15 mgs. He was being, undertreated, probably because of the age or probably because of something else, but that was an underdosing. So yes, option B, lansoprazole increased to 15 milligrams twice daily is the right option. So that's very good for all of you guys. Right? Now going to peptic ulcer disease. So our case 2 is a 42 years old male with sharp epigastric pain for 6 weeks. Pain is worse with eating and present approximately 5 days per week. So it's most of the days of the week. Some relief is there with over-the-counter NSAIDs. His current medications are NSAIDs as needed. He's allergic to sulfa. Urea breath test for H. pylori. Urea breath test for H. pylori is positive. So this is an H. pylori case. How do you treat that? So look at the treatment options. A is amoxicillin 1 grams, BID plus clarithromycin 500 milligrams, BID plus omeprazole 20 milligrams, BID for 5 days. Then there's cephalexin 1 grams BID plus clarithromycin plus omeprazole for 10 days. Then there's bismuth, tetracycline, metronidazole, omeprazole for 14 days. days. And then there's levofloxacin plus metronidazole plus omeprazole for 21 days, right? So going to the peptic ulcer disease and H. pylori. So specifically for peptic ulcer disease, the symptoms are being that's my mnemonic. You can use it, or you can use it to remember or not. It's belching, epigastric pain, anorexia, and nausea. So Mr. Bean is the symptoms of peptic ulcer. Etiologies are hence Helicobacter pylori and Nsaids use. These are the two basic etiologies of peptic ulcer disease. So specifically talking, the two main reasons of peptic ulcer disease are H. pylori and Nsaid use. For the diagnosis, usually the non-invasive techniques are preferred over the invasive ones. You want to go with the non-invasive ones. You don't want to do the invasive ones, but the invasive ones are histology and culture. They're all prone to error because of the culturing technique. So it all depends upon the quality of culture that's been taken and the quality of the histology sample that's been taken. A rapid urease test is also an invasive endoscopic test. The non-invasive test is usually, remember it as the SIRAF non-invasive test karna chahte hain, invasive nahi karna chahte. So SIRAF is serologic IgG, immunoglobulin test. U is for urea breath test, and F is for fecal antigen test. So सिर्फ हम non-invasive पे focus करते हैं. So this is serologic IgG, urea breath, and fecal antigen test. So tests which are affected, the important thing to remember is what tests are affected by anti-secretory therapy. So if the patient is continuously on a PPI and the patient is on an H2 receptor antagonist, the following tests may be affected. The result, they may come out as false negative. So fecal antigen test or urea breath test or rapid urease, any test involving the urease may be affected by PPI since it increases the pH of the intestine. So because of that, the urease production at that time may be reduced and you may get a false negative test for the H. pylori, right? So serum IgG test is not specific for eradication. It's not specific for eradication since it stays positive for a long period of time, like all IgGs do. So if a patient has symptoms and has a positive IgG, he is H. pylori positive and you want to treat him. If the patient has just an IgG and has no symptoms, means that the patient may have had an H. pylori infection in the past and he is now clear from that particular infection. Right? So the treatment, I'm just going to discuss the crust and I'm not going to go into the details of all the research trials that are available. There are two basic therapies that are there and that should be followed. One is the clarithromycin triple therapy and the other is the bismuth containing quadruple therapy. So the clarithromycin therapy is a PPI, like we said, it's the poppy of everything. So it's going to be there. So PPI is there, and then a clarithromycin is 500 milligrams BID and amoxicillin or metronidazole for 14 days, right? So a 14 days therapy of PPI, clarithromycin, and amoxicillin or metronidazole. The bismuth quadruple therapy is BMTP. So it's bismuth, it's tetracycline, metronidazole, and a PPI for 10 to 14 days, right? So coming back to the case again, it's a 42-year-old male with sharp epigastric pain for 6 weeks, and we are going to treat him for H. pylori. So which options do you guys suggest? Option C, Alishba. Hi, Alishba. Anam C. So option A, let's discuss this. Option A is amoxicillin, clarithromycin. This all looks good, but look at the duration. It's 5 days. So you're going to undertreat the patient, right? So it's not going to be good. Option B, cephalexin. So there's no evidence of switching from a penicillin to a cephalosporin for no reason. And cephalexin has no evidence in H. pylori also. So there's no point. Similarly, option D, levofloxacin and metronidazole, there is too much less data on fluoroquinolone containing regimens. And the duration also is wrong, 21 days. So you don't treat the patient for 21 days, right? So correct answer is Bismuth 4 times, this is BMTP, the quadruple therapy of bismuth. So another benefit of bismuth quadruple therapy is that usually in our parts of the world, like in the South Asia, macrolides and fluoroquinolones, they're available over the counter. Like they're prescriptions, strictly prescription drugs, but you can get it on any pharmacy. So in that case, if the patient has had previous macrolide exposure, and what with the pandemic and the risk of this COVID, we have like overused azithromycin. So such patients, if present with H. pylori, this previous exposure may lead to resistance. So probably in that case also, if the patient has had a previous exposure to a macrolide, you also want to choose the quadruple therapy over this clarithromycin containing triple therapy, right? So that's why we're going to choose option C. So NSAID-induced peptic ulcer disease, since we know that NSAIDs are one of the main reasons, along with H. pylori, for peptic ulcer disease. So the less toxic ones are, if you have a patient who needs an NSAID, and the patient also has peptic ulcer disease, you want to choose either ibuprofen or diclofenac or nabumetone, since they're less toxic. Naproxen is moderately toxic, and highly toxic are like indomethacin, ketorolac, piroxicam, right? These kind of drugs. So the first choice is again a PPI, and we have a product in the market, Vimovo, with naproxen and esomeprazole combined together. Misoprostol is also another option, but they're frequent dosing, like you need to give it 4 to 6 hours a day, every 4 to 6 hours, which may be too much for somebody to continue for a long period of time. So, and H2 receptor antagonists are inferior to PPI and misoprostol in NSAID-induced peptic ulcer disease. So if you have a peptic ulcer case, you don't choose an H2 receptor antagonist, choose a PPI. Upper GI bleeding. So we're going to discuss this in the liver part also. For the GI bleed, your main focus is maintaining the fluid. Since the patient is losing a lot of blood, the important thing is resuscitation and the fluid replenishment to make sure the patient does not go hypotensive. And the other important thing is that you maintain hemoglobin concentrations of at least 8. So any hemoglobin 7 or less than 7, you need to transfuse blood, right? That's important. And a patient who presents with emergent GI bleed, you do endoscopy within 12 to 24 hours. So that's superior to everything else. So sclerotherapy for coagulation of the blood in the vessels, there are agents available, and then thermal coaptative therapy for band ligation, that's also an option. Moving on to our next section, ulcerative colitis and Crohn's disease. So let's have another case. This is a 35-year-old male with mild to moderately active ulcerative colitis confined to the descending colon and rectum. So it's a confined disease in the descending colon and in the rectum. His past medical history is he has ulcerative colitis and he has seasonal allergies. His current medications are loratadine for seasonal allergies only. So which regimen is best at this time for this particular patient? Is it belsilazide 750 mg twice daily? Is it MTX 25 mg IM? Is it infliximab, a TNF alpha inhibitor? Or is it mesalamine enema 1 gram rectally once daily? So we think on it while we coming back. Sophia already has an answer. Let's see. So the clinical features of irritable bowel disease. So we need to differentiate between what is ulcerative colitis and what is Crohn's disease. In terms of the bowel involvement, the ulcerative colitis usually is more localized in the rectum and in the colon, while the Crohn's disease is mouth to anus. So it's more, gross as compared to ulcerative colitis. Usually in ulcerative colitis, there is no perianal involvement, but in Crohn's disease, there is anal involvement also. Ulcerative colitis usually is very superficial. Crohn's disease is more in depth, more submucosal, more deeper. And because of that, you get a lot of fistula and perforations with Crohn's disease. in contrast to ulcerative colitis, where fistulas and perforations are not very common, right? So usually you get a continuous inflammation, like a gross continuous inflammation in the whole region of the rectum or colon with ulcerative colitis. But with Crohn's disease, you get a patchy kind of inflammation. The important thing is that the risk of colon cancer has been associated more with ulcerative colitis as compared to Crohn's disease. Malnutrition is rare with ulcerative colitis, but Crohn's disease is there because since it's mouth to anus, so usually patients go off food and they usually have malnutrition. And pseudopolyps are common in both of them, right? So just to differentiate on the basis of the presentation, how do you differentiate? Crohn's disease usually is more extensive since it's mouth to anus and it's more deep. Ulcerative colitis is usually localized in the rectum and it's usually, there may be exceptions, it usually is localized to rectum and colon, and it's superficial. So how do you treat them? Mild to moderate and moderate to severe. You differentiate them on the basis of the diarrhea and the systemic symptoms. So if there is less than 4, it's mild, 4 to 6, it's moderate. Anything more than 6, like 8, 10, 14, you call it as severe and fulminant. Does somebody have any question? I don't know what happened. Okay, so mild to moderate, as I was saying, is 4 to 6 is okay, stools and no systemic symptoms or mild systemic symptoms. But severe is like you get more than 8 stools per day and there's systemic symptoms, and there may be hypotension along with that, and all the this series of symptomology that you get along with severe diarrhea is there. So in ulcerative colitis, when you're treating mild to moderate, you look at the extent of the disease. Is it extensive or is it just one portion? If it's extensive, you give a systemic aminosalicylate or a budesonide. Budesonide, which is called as a topical corticosteroid based on its place of action. It's very poorly absorbed from the intestine, so it remains localized, and that's why it has less systemic adverse effects as you see with corticosteroids, and it's very good for the ileal portion of the intestine since most of its absorption is there, right? So for extensive disease, mild to moderate case, you give either aminosalicylate or budesonide. If it's a left-sided disease where you need to cover spleen, some portion of the pancreas, you give an enema of the aminosalicylate. If it's rectal, you give a suppository of the aminosalicylate, right? So you can target the organ. If it's extensive, you give systemic. If it's targeted, you try to give the targeted therapy, localized therapy like an enema, which will go up to the left side. And if it's rectal, you take a suppository. If it's moderate to severe, you have to give a TNF-alpha inhibitor or plus minus azathioprine. So you need to give immunomodulators plus minus corticosteroids for short term, which obviously is going to be budesonide. And if these therapies do not work, then you have integrin inhibitors also, Natalizumab and tofacitinib, if unresponsive to TNF-alpha inhibitor, right? So for moderate to severe, you choose a TNF-alpha inhibitor, add-on or minus based on the clinical presentation and the response of the patient, immunomodulators like azathioprine or 6-mercaptopurine. With Crohn's disease, it's more or less similar to ulcerative colitis. There are few changes, a few variations, which we're going to see here. In the mild to moderate portion, they're all same, like the ulcerative colitis. But in the moderate to severe case, TNF-alpha inhibitor with azathioprine or 6-mercaptopurine or methotrexate. So methotrexate is a drug for Crohn's disease only. It's not for ulcerative colitis. There's no evidence of methotrexate in ulcerative colitis. There's only evidence in Crohn's disease. So you give a TNF-alpha inhibitor with a definitive therapy of an immunomodulator like azathioprine, 6-mercaptopurine, or methotrexate, right? So this is the difference. Like you have plus minus in ulcerative colitis, but with Crohn's disease severe cases, you combine both of them, plus or minus. And in that you can add a short-term budesonide to improve the symptoms. And if this doesn't work, then obviously the options are vedolizumab or tofacitinib if the patient has not responded to TNF-alpha, right? So just to have an idea of these monoclonal antibodies, every now and then we see another mAb in the market. So infliximab is murine, adalimumab is human, certolizumab is pegylated. Etanercept धक्के से बीच में आ गई है क्योंकि मैंने पिक्चर कहीं से ली है so इस तरह से इसका कोई रोल नहीं है. Etanercept has no role in Crohn's disease or ulcerative colitis. So how do they work? You may get a there are a question or two based on the mechanism, and we also should know how our drugs work. So minosalicylate, just to cut long things short, it reduces leukocyte recruitment in the bowel wall. It decreases the chemotactic response to leukocytes, so decreases inflammation. So you see, ulcerative colitis and Crohn's disease, these are immune-mediated diseases. So you want to reduce the immune response to make sure that the therapy is working. So it reduces leukocyte adhesion. Corticosteroids obviously are immunomodulatory agents. 6-mercaptopurine is a purine antimetabolite. Azathioprine is a prodrug of 6-mercaptopurine. So it's actually 6-mercaptopurine in the body, but it's just one step more. Methotrexate is DHFR, a dihydrofolate reductase inhibitor. So it inhibits the reduction of BH2 to BH4. Tofacitinib is genus kinase inhibitor. So it reduces, it inhibits the pathway of proliferative proteins to cut long things short. Infliximab is a chimeric monoclonal antibody, and it acts against tumor necrosis factor alpha. So whenever there is macrophage activation, TNF is intracellularly formed, it activates, and this whole pathway of inflammation, production of inflammatory cytokines and interleukins starts. So the TNF alpha inhibitor is actually going to inhibit this process, right? Adalimumab is the humanized monoclonal antibody. Certolizumab is the pegylated. So all of them are the same, and they have the similar evidence. Golimumab is IgG-K, so it's the antibody version. Natalizumab is an integrin inhibitor, but it's not specific. It inhibits integrin in the brain. Also, it crosses the triple blood-brain barrier. So it also has role in multiple sclerosis. And because of this ability to cross, it also has more side effects. Vedolizumab binds to the alpha-4b7 subunit, which is specific to the gastrointestinal tract. So it is more specific to the GI and hence has less systemic side effects as compared to natalizumab. Ustekinumab is an interleukin 12 and 23 inhibitor, right? So just a case, you're managing irritable bowel disease in a sulfa-allergic patient. Which of the following drugs should be avoided? So we just discussed the aminosalicylate, and you have to treat a patient with aminosalicylate, and the patient is sulfa-allergic. Which drug will you avoid? Sulfasalazine, mesalamine, oxalazine, belsalazide, all of the above. Which one will you avoid? Any answers? So the mesalamine, oxalazine, belsalazide, these are non-sulfa drugs. Mesalamine, oxalazine, belsalazide. नाम से तो ऐसे लग रहा है कि ये sulfa हैं, but they're non-sulfa. They can be used in sulfa allergy. Sulfasalazine is the actual sulfa drug. तो ये पुराने ज़माने की दवाई है, वो जो 45 के बाद सेकेंड वर्ल्ड वॉर के बाद sulfa drugs आई थी. तो ये 1960-1965 की दवाई है. So that's the pure sulfa drug. So sulfa allergy, may you avoid sulfasalazine. Mesalamine can be given, oxalazine can be given, belsalazide can be given. Right? So safety concerns of irritable bowel disease treatment. So with aminosalicylates, obviously you talk about, these are my mnemonics and just explaining it to you. So SHHFP. So it's like it's a sulfa drug. With sulfa drug, sulfa allergy is a case. Hemolytic anemia, hepatotoxicity, headache, folate deficiency. Folate deficiency is an important side effect. Fever is there. It causes pancreatitis. Minosalicylase can cause pancreatitis, right? And also pneumonia. So risk of infections is there, risk of hemolytic anemia is there, risk of folate deficiency, and obviously sulfur allergy is another case. With corticosteroids, we all know the issue of glucose intolerance, right? Risk of diabetes, adrenal suppression, right? Is there sodium and sodium retention and water retention? Is there hepatotoxicity? Is there osteoporosis with corticosteroids and cataract? So these are the major adverse effects of corticosteroids. Okay, so with azathioprine, obviously bone marrow suppression, nasopharyngitis, pancreatitis is there. And the important thing with azathioprine and 6-mercaptopurine is the thiopurine methyltransferase enzyme deficiency. So patients who are deficient in thiopurine methyltransferase are going to have increased levels of azathioprine as well as 6-mercaptopurine in the body. So TPMT, what it does is that it converts azathioprine and 6-MP to 6-thiouuric acid, which is the inactive form and gets excreted out of the body. If TPMT is deficient, there's going to be less metabolism in the inactive form and increased levels of the drug and hence toxicity. So patients may present with severe neutropenia, or severe cytopenias. Patients may present with grade 3 to grade 4 diarrhea, and this could be problematic. So you need to look for another option for such patients who are TPMT homozygously deficient, or reduce the dose. So with methotrexate, it's a systemic chemotherapy. It causes every toxicity. It causes pulmonary toxicity, hepatotoxicity, bone marrow suppression. So you name the organ and MTX causes the toxicity of that organ. So very toxic drug. So natalizumab and vedolizumab, with natalizumab, the important point is leukoencephalopathy. So since it crosses the triple B, it can cause progressive leukoencephalopathy, which can be identified. How you identify it? Like, the patients may present with complaints of decreased organization of thoughts and abnormal behavior and abnormal gait and somnolence. It's a fatal disease, right? And it may be there with natalizumab. Vedolizumab, as we discussed earlier, is specific to the gastrointestinal tract. So the systemic adverse effects are less. So with TNF-alpha inhibitors, you get the infusion reactions, you get fever, and you also may have the risk of hepatosplenic lymphomas when combined with azathioprine and 6-mercaptopurine. So patients who have been given TNF-alpha inhibitors along with azathioprine and 6-mercaptopurine, the incidence of hepatosplenic lymphomas is higher. But having said that, this risk should not affect the decision of using the combination, because the decision to use that outweighs the risk, right? Excuse me. So ustekinumab, obviously the risk of infections is there. Excuse me. Coming back to the patient's case, it's a 35 years old male with mild, moderately active ulcerative colitis confined to the descending colon. So what would be the treatment for this patient? So we know that this is a descending colon and rectal disease. It's more left-sided. So any options that you guys would like to choose? Any options you'd like to choose?
Students are selecting D, doctor.
Oh, sorry, I'm a bit like, oh, very nice. So discussing the options, it's a left-sided disease. Very good. Sahar, Anam, and everybody, you guys are all going very fine with the options and your judgment. Belcelazide is a systemic therapy. We may choose that, but since it's a localized disease, you don't want to do a systemic therapy for such a patient who does not have an extensive and a severe disease, right? So, and methotrexate would be a drug for Crohn's disease. It's not the drug for ulcerative colitis. Infliximab, a TNF-alpha inhibitor, will be a drug for cases which have failed on the primary therapy, right? So yes, you guys are very right. Mesalamine enema, 1 grams rectally would do for this particular patient. Very good. So next case, patient C is planned for ulcerative colitis maintenance therapy with azathioprine 2 mg per kg per day orally. Homozygous TPMT deficiency is detected. Which of the following do you expect? So this patient is on azathioprine and has TPMT deficiency. Very clear. So do you expect decreased conversion of prodrug to active or a therapeutic failure? Do you expect increased azathioprine levels? Do you expect increased risk of disease relapse? So for azathioprine, the conversion to 6-mercaptopurine is through 8-GPRT. That's another enzyme. This patient is not deficient in that enzyme. We don't have any information of that. We have the information that he's deficient in TPMT. So we know that the active is not going to be converted to 6-thiauric acid. So the option is very clear. It's C. So as I said, yeah. So Ashna, as I said, that conversion of azathioprine to 6-mercaptopurine, your thinking process is very right, mashallah. You're thinking that probably there's no metabolism and it's being converted to the active. So let me make this very clear. So there are 2 steps to the metabolism of azathioprine. One is conversion of azathioprine to mercaptopurine. That is dealt by 8G hypophosphoguanosine ribotransferase. That's the enzyme, 8GPRT. That's another enzyme. Now, conversion of 6-MP to 6-thiauric acid is by thiopurine methyltransferase. So this enzyme actually is specific for inactivation of the active. This patient is deficient in that. That's why there is chance of increased azathioprine level in the body. So that's why we don't choose A and we choose B, that there are chances of grade 3 to 4 diarrhea, severe cytopenias with azathioprine. So moving on to our next case. This is a 58-year-old adult male, is a case of alcohol-induced hepatic failure, is childpachy with massive tense ascites. Is planned for large volume paracentesis, which is a total of 6 liters. What dose of albumin would you recommend to be administered alongside? So let's do the thought process on this while we discuss in the next slide. So let's talk about ascites. Now, ascites, obviously, we know the abnormal accumulation of the fluid because of liver failure, right? So what you do is you do dietary sodium restriction to less than 2 grams per day. You give a diuretic. Usually furosemide and spironolactone are the drugs. If the patient is refractory, you choose an alpha agonist midodrine to be added to the previously existing therapy. So you add midodrine to furosemide and spironolactone if the patient is refractory, that is, the ascites do not improve. If the patient has gynecomastia, which is a major adverse effect of spironolactone, you can switch the patient to amiloride. For tense ascites, you need to do large volume paracentesis. Any volume which is more than 5 liters, you give 6 to 8 grams of albumin per liter of the fluid removed. 6 to 8 grams per liter of the fluid removed to make sure that the patient maintains his saturation, right? Excuse me. So in this patient, he has to remove 6 liters. So what dose of albumin do you recommend? Is it 8? Is it 24? Is it 36? Is it 60? Or do you think that albumin administration is not recommended unless paracentesis volume is more than 8 liters? Any comments about option E? So any volume removed above 5 liters is a large volume, right? So option E is not correct. So we are going to, since this patient has removed 6 liters, has to be removed 6 liters from the body, you need to give 6 to 8 grams per liter. So 6 to 8 grams per liter. Either you give 36 grams of albumin or you give around 48. So something between 36 to 48 grams, right? Is it clear? So option C should be the right option. I haven't had any answers. Is it clear? I can repeat that. So moving on, another case. This is not a case, just a question. What is the mechanism of action of midodrine? So you get a question or two in your exam based on the mechanisms of action. You can get a mechanism of action. I got there was some monoclonal antibody. I remember I was asked this question. So you can get asked about the mechanism. Midodrine, as we discussed in our previous slide, is an alpha-1 agonist. It increases renal perfusion and enhances diuresis, right? So it is an add-on therapy to the previous diuretic therapy, furosemide and spironolactone, if the patient has refractory ascites, right? So moving on to our next section, gastroesophageal varices. So as we discussed in the upper GI bleed, you maintain hemoglobin more than 8. The treatments, just the pearls. I'm not talking about the details because of shortage of time. Octreotide is a drug. Vasopressin is second line. Ceftriaxone should be added. So octreotide is a drug of first choice. It's a somatostatin analog, but you watch for hyperglycemia. So monitor blood sugar levels. Vasopressin is the drug of second choice, right? If the patient has like significant hyperglycemia, but vasopressin has more systemic adverse effects. So you watch for ischemia, you watch for hypotension, right? So these are significant adverse effects. So probably not a drug of first choice. Also, with vasopressin, internationally, dosing errors are very high since it's dosed in units. In bleed cases, there is emergency. So you see in an emergency case, when you're dosing something by units and you have to remember that this is not milligrams and you're dosing everything based on milligrams and grams, and you have to dose something as units, the chances of error are higher. So this is significantly reported also by ISMP. The vasopressin dosing errors are very significant. So probably also that is a contributing factor to it being a second line therapy and not the first line. Antibiotics always help. There is reduced short-term mortality. Ceftriaxone is better than anything else, right? So since it covers the gram-negative bacilli, which is usually what you want to cover in varices. So prophylaxis is with non-selective beta blockers, propranolol, nadolol, carvedilol, and prophylactic band ligation is also a recommendation. It is superior to sclerotherapy, right? Another case, this is a 42 years old. This is a 42 years old child, Park C, is admitted with severe abdominal pain, fever, and vomiting. Abdomen is tense and tender. He has pitting edema. Acidic tap shows turbid fluid. Cultures are pending. Serum albumin is 2.5, WBC 7, serum creatinine 0.8, BUN 25, Billy 3.2. So a lot of labs, right? Which is the best course of action? Now this patient presents to you as child Park C. His abdomen is tense and tender. He presents as infectious, right? So what we're going to talk about here is spontaneous bacterial peritonitis. So patient is presented to you. This is an acute emergency. The first line is third generation cephalosporins, cefotaxime or ceftazidime, because you want to cover Klebsiella, you want to cover E. coli, you want to cover Streptococcus, all the gram-negative and gram-positive bacilli of the intestine. Right? So you want to give third generation cephalosporin in this first line. Fluoroquinolones can also be chosen if there is no previous exposure. But where would you find a patient who does not have a previous exposure to a fluoroquinolone, to be very honest? So yes, drugs like third generation cephalosporins are the drugs of first choice. You add albumin if 3 of the following are there. Serum creatinine is more than 2. Bilirubin is more than 4. BUN is more than 30. So if these 3 conditions are met, this patient is significantly, has a significant infection, which may lead to sepsis. right? So you need to add a replenishing fluid, a colloid also. So you add albumin in the therapy if the patient's serum creatinine is more than 2 and bilirubin is more than 4 and BUN is more than 30. Now getting back to this patient, look at his albumin. 2.5, WBC 7, creatinine 0.8. It's not more than 2. BUN is 25. It's not more than 30. Bilirubin is 3.2. It's not more than 4. So this is not a high emergency case, but it's a case of spontaneous bacterial peritonitis. So what would you choose? The drug of first choice? Any options? Amikacin and albumin? Cephalexin plus albumin, or albumin and await cultures? Any answers, please? Oh, I already gave the answer. So amikacin, why don't you choose amikacin? This patient has renal impairment. This is not the drug. Aminoglycosides are not the drugs for any patient who involves any abnormality in the kidney. They're highly nephrotoxic. You don't torture the patient with aminoglycoside, never give it. Cephalexin plus albumin is the wrong option for the obvious reasons that we just discussed. And just giving albumin and not treating the bacteria is not going to make sense, right? So you choose the right option B, which is a 3rd generation cephalosporin, right? Now moving on to hepatic encephalopathy. How much time do we have? Okay, so this is a 56-year-old man, is admitted with 2 days history of confusion, disorientation, somnolence, and reduced oral intake. On exam, he's afebrile, abdomen is tender, reduced reflexes, dry mucous membranes, and asterixis. So this is an encephalopathy case. Asterixis is the abnormal posture of the hands in patients with encephalopathy. So आपने कभी देखा होगा aged patient who have liver abnormality, वो कुछ अलग तरीके से हाथ दिखेगा, जैसे posture थोड़ा खराब होगा. So that's what you call as, yes, it's very significant or specific symptom of encephalopathy. This patient has cirrhosis, class B, alcohol abuse. This patient is on propranolol. Paracentesis is negative for infection, right? So which treatment is best for this case is actually talking about the treatment for hepatic encephalopathy. Is it rifaximin, lactulose, PEG, or ceftriaxone? So encephalopathy has 3 types. A is acute, B is because of bypass or shunting, C is because of cirrhosis. So we rate encephalopathy from covert to overt. Any grade 1 encephalopathy which has trivial lack of awareness, trivial anxiety, and impaired performance, that we call as covert encephalopathy. Any grade 2 like lethargy, apathy, subtle personality change, somnolence, confusion, like our patient in the case, that's an overt encephalopathy, right? So the first choice is always lactulose. You add on rifaximin and can do the maintenance, and neomycin and metronidazole can be alternatives. But a lot of cases of encephalopathy include renal impairment because of hepatorenal syndrome. So you may not want to do that. And especially if you're choosing metronidazole, you want to see for patients who have had alcoholic cirrhosis and encephalopathy, since with metronidazole, you may get a disulfiram reaction in patients who are alcoholic. So a lot of things to see if you're choosing neomycin and metronidazole. So the rule of thumb is always start with lactulose, and if the patient is refractory and does not improve, you can add rifaximin as maintenance, right? So coming back to the case again, you look at the options. Which treatment is the best? Rifaximin, lactulose, PEG, and ceftriaxone. So rifaximin, as we said, is the maintenance. Ceftriaxone is an antibiotic and could be an add-on, but not the primary one. PEG is usually the 4 liters over 4 hours is the usual dose and the drug that we do. So option B, lactulose, 30 mils PO every 2 hours is the right option for this patient. Dr. Reda?
Yes, ma'am.
Can we go for a bit more?
Yes,
I just have to cover.
Yes, please.
I just have to cover hepatitis and then we'll be done with it.
Yes, we have time, ma'am. You may
Okay,
continue.
so just 10 minutes more probably. Thank you. So for hepatitis B, just the pearls of that. I'm not going to go into the details. Entecavir and tenofovir, the reverse transcriptase inhibitors. So these are the drugs of first choice. Treatment is 1 year. Peg interferon, that's also an option, but the safety concern is an issue. Cases which are surface antigen negative, HBeAg negative, they are severe since they're not presenting the antigen and there may be mutation. So you need to treat them longer. So you must treat more than 1 year with entecavir and tenofovir, and with peg interferon, it's 1 year or more than 1 year. The important thing is if you see resistance. So you see with these medications, when you give it for 3 months or more, the chances of the virus adapting to them and resistance. You start as late as possible, right? So if there is lamivudine, talbivudine, and entecavir resistance, you add tenofovir or you switch to tenofovir. If there is adefovir resistance, you switch to entecavir. If there is multi-drug resistance, you combine tenofovir and entecavir, right? You don't have any other options. So you combine the two of them to have an added effect. So the concerns is important, like with peg interferon alpha, you have bone marrow suppression, you have psychosis. There's a boxed warning for peg interferon for psychosis and agitation and mania, right? And cardiovascular events, peg interferon. These are the concerns. So it's like a toxic medication. That's why it's going out of the block. Tenofovir, with tenofovir, the most important thing is the renal insufficiency. So it's not a drug for patients who are renally insufficient and may also cause nephrotoxicity, right? It also causes nasopharyngitis and it causes decreased bone mineral density. So bone adverse effects, nasopharyngitis, renal impairment. These are the concerns with tenofovir. Entecavir is a relatively safe medication. There are some abdominal symptoms and very rare reports of lactic acidosis, right? So whenever you choose a patient, choose on the basis of that. Now moving on to the important thing, the hepatitis C. It's a 38 years old male with chronic hepatitis C genotype 1A. So genotypes are important. We're going to discuss compensated disease. It's a compensated disease. Labs are these. So the important thing is that the hepatitis C virus RNA in this patient is 950,000. Serum creatinine is 1, hemoglobin is 12. Liver biopsy is Metabolism F3 that shows compensated cirrhosis. What is the most appropriate course of action at this time? Either it's no therapy and reassess in 12 months, you initiate sofosbuvir and cimeprevir, you initiate sofosbuvir and ladipasvir, or you initiate peg interferon, ribavirin, and sofosbuvir. So you think, you all do the thought process while we discussing this. Hepatitis C. So there are 6 genotypes, 1 to 6. You screen all susceptible patients, all susceptible persons, people who do regular transfusions, IV drug users, transplant patients, immunocompromised patients, right? You test all of them. And the new thing about therapy of hepatitis C is that you treat all cases unless there is short life expectancy. Previously, we didn't used to do that. When we did not have enough options, we are concerned about the resistance. So we treat it as late as possible, as we do in hepatitis B, because of the chances of resistance, right? But in this case, in case of hepatitis C now, with the options that we have and the SVR rates that we have, we treat all cases unless there's very short life expectancy in the patient. And your goal is measured by the sustained virologic response, SVR. SVR is your goal. So after the completion of the therapy, 12 weeks or more of sustained virologic response is what calls complete remission from hepatitis C, right? So over the years, we have had a lot of progress, you see. The sustained virologic response has increased a lot once we have had direct acting antivirals. So just to have a brief idea of where do our drugs work, since we're going to have a lot of difficult names when it comes to hepatitis C treatment. So to summarize everything short, NS3, 4A inhibitors act on the inhibition of RNA translation. 5B inhibit the polyprotein processing. and these were 5A. Sorry for the typographical mistake. The second row is NS5A inhibitors. They inhibit the polyprotein processing, and 5B inhibitors inhibit the RNA assembly and release, right? So just to know which drug is what, as a key to this, all the 3,4-A protease inhibitors, the 3,4-A inhibitors are the protease inhibitors. They have the numeric R, PR, boceprevir, talaprevir, cimaprevir, esomeprazole, grazoprevir, right? Gynecomastia. So all of these drugs have PR. So these are protease inhibitors. They have PR in their names. 5A inhibitors have ASWER, A starting from A, NS5A, Declatasvir, Ledipasvir, Omeprazole, Elbasvir, Pibrentasvir. So all drugs, they start from, you can remember from A. NS5A inhibitors have ASWER, right? NS5B inhibitors have Buvir, B, starting from B, NS5B. So it's very easy to remember. So Sofosbuvir, Beclabuvir, Dazabuvir, right? So 3,4-A protease inhibitors are Previr, 5A are Aswir, and 5B are Buvir as the mnemonics, just to remember. So this is the list of all the approvals we have had. We've had a lot of advancement in the therapy. And we've had a lot of drugs. Pakistan में अभी तक मेरा ख्याल है कि हम Velpatasvir तक पहुंचे थे पिछले साल. If somebody has an idea कि अब हम कहाँ पहुंचे हैं, I don't remember the last drug that we have had, but Velpatasvir was available. So these green ones are the approved, the recently acclaimed guideline therapies. So Sofosbuvir, Ledipasvir, Sofosbuvir, Declatasvir, Elbasvir, and Grazoprevir, Zepatier, Apclusa, a very famous Sofosbuvir and Velpatasvir, Vazavi, and Maviret. The Maviret is very fresh on the shelf, and it's very famous these days, right? So genotype, just to summarize everything, you treat it for, as the rule of thumb is 12 weeks. You treat it for 12 weeks. There are few like Glycaprevir and Pibrentasvir, you can treat it for 8 weeks in genotype A, 1A, right? So these are the abbreviations. So Elbasvir and Grazoprevir, Zapatier, this is for 12 weeks. So it treats 1A, 1B, and all of them. Ledipasvir and Sofosbuvir is there for 12 weeks. Glycaprevir and Pibrentasvir is there. And Velpatasvir and Sofosbuvir, Apclusa, this is also for all genotypes, right? So you can just use it as a key when you're trying to remember. There are a lot of remembering that needs to go on when you're dealing with these drugs. So the important things to remember, I've just summarized the things which are important that we need to remember with these drugs. So with Sovaldi, Sofosbuvir, the important thing is you don't give it when the creatinine clearance is less than 30 mils per minute, right? And with all P-glycoprotein inducers and CYP3A4 inducers, there is reduced activity of Sofosbuvir, right? And also with amiodarone. So the important thing is the interactions, the risk of bradycardia with amiodarone, and amiodarone is a long-acting drug, it is a long half-life. So you may see it very significantly over a period of time. You need to be cautious when giving the two of them. Probably switch it. Sofosbuvir, don't give it. Also the patients who have renal impairment or patients who are on reducers like rifampicin, St. John's wort, ये Pakistan में हमने कभी use नहीं की, but it's very common in like American population and North American population to use it as a lot of modalities. So Harvoni, which is Ledipasvir and Sofosbuvir, the second drug, it's once daily doses with or without food, and it cannot be given in creatinine clearance less than 30 mils. Right, because of Sofosbuvir. Zapatier, which is Grazoprevir and Elbasvir, the benefit it has is that it can be used even in hemodialysis also, and it can be used in renally impaired cases since it's safe in that. But it has hepatotoxicity, so if the patient comes to you with child-pox B or C, you don't give Zapatier, you don't give Grazoprevir or Elbasvir, you choose Harvoni, like Ledipasvir, Sofosbuvir, or Sofosbuvir alone with another combination, right? So you need to weigh out the comobs in the patient. Epclusa is velpatasvir and sofosbuvir. It's also once daily dosing, and because of sofosbuvir, you don't give it if the creatinine clearance is less than 30. And also for the inducers, we all know that. And another important thing is that velpatasvir levels are affected by proton pump inhibitors, right? So the levels may be higher, the adverse effects may be higher. With Mavorite, it's a new drug. And the important thing with this new product, glycaprovid and pibrentasvir, this combination is that even if the patient has been previously treated with NS5A or NS34A inhibitors, this combination can be used. The previously used combinations like Harvoni or Swaldi alone or Epclusa, they have not been tested in patients who have had a previous exposure to another combination. But this combination, Mavorite, can be used for patients who have had either of the two, like either an NS5A inhibitor or NS34A inhibitor, not the two of them, like not the both of them, but one of them. So it's a 3 tablets daily with food, and it's 8 to 16 weeks. And another positive thing is that in genotype A treatment, you can get the patient in complete remission by 8 weeks of the therapy. But if the patient presents with another genotype, you can extend the therapy up to 16 weeks also. And also, if the patient has had a previous exposure to an NS5A or NS34 inhibitor, you need to continue it for longer, like 12 to 16 weeks, right? Vozevi is the last drug that we're going to discuss. It's once daily dosing, and it's also a 1 to 6. And this drug is also approved for cases that have been previously exposed, right? So coming back to our case, this was a 38 years old male, and he had HCV RNA of 950,000. His serum creatinine was 1 milligram per DL, and 1 is like a normal milligram per DL, like a normal serum creatinine. Hemoglobin is 12. Liver biopsy shows compensated disease. What is the most appropriate course? Any ideas? If you're still there, if you're not tired. Any ideas? No ideas? किधर चले गए सब? So either you know therapy. Oh,
Ma'am, they are responding in the chat box, I guess.
My chat box probably has stuck. Or I'm not getting anything. Okay. So let's discuss this. So no therapy, DSS, and sorry.
Students are answering C.
C. You guys are thinking very good, mashallah, mashallah. So let's discuss this. So no therapy, we don't agree, since the latest in the guidelines say that there's always benefit of treating unless there's very short expectancy. This is a compensated disease, so we do know that we need to treat. Sofosbuvir and Cimeprevir is an older combination. It's not in the guidelines now. Option D, PEG interferon, ribavirin, and sofosbuvir, again, is an old combination. It's not recommended now because of the adverse effects of ribavirin and PEG interferon. I could not discuss ribavirin today because of the shortage of time, but yes, sofosbuvir and ledipasvir, Harvoni, this is a recommendation and this should be used. So mashallah, our thought process is going very fine. So we are choosing the right drug for our patient. So the last thing is irritable bowel syndrome. We're just going to touch on that. So this is a 32 years old female with crampy abdominal pain, bloating, and constipation for the past 6 months. She has irritable bowel syndrome, constipation predominant, labs are okay. How do you treat her? So either you give amitriptyline 50 mg per day or VSL, which is a probiotic, 3 capsules per day, Tagacerod 6 milligrams twice daily, or lubiprostone 8 micrograms twice daily. How do you treat? So irritable bowel syndrome is constipation predominant, IBS-C, IBS-D is diarrhea predominant and mixed. We have a lot of choices for them. For the diarrhea symptoms, you can choose loperamide, which is an opioid antagonist. It can treat the diarrhea, but it cannot treat the pain. We should not think that it's an opioid and it will treat the pain. It does not treat the pain. So you need to add something for the pain also. For probiotics, it improves global symptoms. And yes, it helps in the pain also. Opioid agonist antagonist Elixodolin, that's also been used, but the risk of biliary obstruction and pancreatitis is significant. So you need to watch for that for Elixodolin. Antibiotics like rifaximin can be given, and 5-HT3 antagonist alocetrone is the last in the list. So it's not a drug of like first choice. It's a second line after failure of the other therapies, as the risk of ischemic colitis is significant with alocetrone. So you do not choose it unless you don't have any other option, right? So for the diarrhea predominant, you have these options. For the constipation predominant, you have guanylyl cyclase C agonists like linaclotide or plecanatide. The important thing to remember with linaclotide is it is to be taken empty stomach. Plecanatide can be taken without regards to the meal. Lubiprostone is a chloride channel activator. It helps with the motility also. So it treats the cause also. So it helps with the motility and also the pain. It's a good drug, and it's approved for females more than 18 years of age. It's not approved for males. So in like American population, there are reimbursement issues if a male is being used lubiprostone. So, but you can use for both of them. For fibers like psyllium and polycarbophil, you titrate slowly, because you see these patients have a lot of pain. And when you give a fiber, it's going to worsen the abdominal discomfort for a while. You don't want to do that. So you just give the minimum possible dose and you increase gradually. And osmotic laxatives like PEG can also be used. So lubiprostone is a chloride channel antagonist, activator, sorry. And it helps with the motility, it helps with the pain also, right? Smooth muscle relaxants for abdominal pain like dicyclomine, hyoscyamin, peppermint can be used. Tricyclic antidepressants like amitriptyline, nortriptyline, imipramine can be used for abdominal pain, diarrhea predominant. Because if you use it in constipation predominant, the risk of constipation itself is a side effect of the tricyclic antidepressant. It's going to worsen that, right? And with SSRIs, they also have some pro-motility characteristics, right? And if the patient has comorbids like depression, they're going to help in that. So coming back to the case, this patient needed for constipation predominant. So you have either amitriptyline, probiotic, tegaserod. So let's discuss tegaserod. So this drug has been actually taken off the shelf now because of the increased risk of myocardial infarction. It was a drug approved for constipation predominant irritable bowel syndrome, but now it's the adverse effects are too significant, right? So it causes, the risk of ischemia is very high and myocardial infarction is high. It's not a good drug. Lubiprostone 8 micrograms daily. So I guess it's very obvious. Any ideas? So amitriptyline is going to worsen the constipation, not a good drug. VSL is going to help with the constipation. It's going to be a good drug, but it does not treat the cause. Tegaserod is a bad drug. Lubiprostone is a very good drug. And she's a female, right? So it's a chloride channel activator. It's a very good drug. So option D would be the right option for this particular patient. And very rightly said, Asma, Sumaya, everyone. This is all from my side today. I hope that I've covered most of the things. There are a few things which are still left, but it's like very hard to cover in 1 hour time. So you guys can look it up in the chapter and we can always talk and discuss. Thank you very much, Dr. Siddiqui, Dr. Rana, Dr. Veda. I'm open for any questions if you guys have.
Thank you so much, Dr. Sidrah, for that detailed and informative presentation. we really hope that our audience have got a full benefit from it. And I